Welcome to the debate. If you walked into an urgent care center, say 10 years ago, the vibe was pretty specific. You were there for convenience. You had a sore throat, maybe a sprained ankle, something like that. It was, transactional medicine. But fast forward to today, and the ground has completely shifted beneath our feet. The modern urgent care has become this critical, high-pressure intersection for behavioral health crises, and frankly, the infrastructure was never built for it.
That is undeniably true. The days of the doc in a box are long over. And the data, it really paints a stark picture of this shift. We're looking at approximately 8 to 10% of adult patients in acute, unscheduled care settings harboring recent suicidal ideation.
I mean, just think about that number for a second. That's potentially 1 in 10 people.
Exactly. So if you look around a crowded waiting room, 1 in 10 people sitting there, scrolling on their phones waiting for antibiotics, they're dealing with a potentially life-threatening behavioral crisis. And the terrifying part? Most of them are there for a totally different reason, a stomach ache, a migraine, and they remain, invisible to the system because nobody asks the question.
And that brings us right to the central question of our discussion today. We're debating the zero suicide framework. This is a massive systemic shift that mandates rigorous universal screening, environmental safeguards, and very strict protocols. So, does this represent the necessary evolution of patient safety? Or does it risk over-medicalizing human distress and, infringing on civil liberties by eroding a clinician's ability to use their own judgment?
It's the classic tension, isn't it? Safety versus liberty, but it's playing out in a strip mall clinic.
Right, and I'm here to argue for the systemic protocol perspective. I believe suicide in healthcare settings is a preventable system failure. We need universal screening, we need an affirmative duty to intervene, and we need to stop relying on gut instinct, which the evidence shows it just fails patients.
And I see why you'd think that, but let me offer a different perspective. I'm here to represent the clinical discretion and civil liberty view. Of course, safety is paramount. No one wants to lose a patient. But zero suicide creates what I see as a liability trap that encourages defensive medicine. When we try to regulate safety through rigid checklists, we risk initiating a dragnet that catches people who don't need to be caught, leading to the massive curtailment of liberty that is involuntary commitment. We have to preserve physician judgment over algorithms.
Then let's get into it. So my position is rooted in the zero suicide framework's foundational belief. Suicide deaths for individuals under the care of health systems are preventable. This isn't just wishful thinking, it's a call for a system-wide transformation. The old way of doing things, what we call targeted screening, where you only ask about suicide if the patient looks depressed or acts distressed, it misses a huge portion of at-risk individuals. We have data showing that universal screening identifies this hidden ideation without negatively impacting clinic flow.
But at what cost? You talk about system-wide transformation, but I see a system being set up for failure. My core argument is that while the tragedy of suicide is, of course, undeniable, this dragnet approach of universal screening in high-speed environments like an urgent care is, it's fraught with peril. Predicting suicide is notoriously inaccurate, so when you cast that wide of a net, you get false positives. You get resource strain.
But isn't catching that one person worth the false positives? I advocate for using validated tools like the ASQ, the Ask Suicide Screening Questions, or the PSS-3. The Joint Commission is very clear on this. Homegrown tools are dangerous and lack of validity. We just can't rely on a clinician's intuition. If a patient screens positive, we need a protocol that triggers automatically, removing ligature points, implementing safe rooms. We have to move from a culture of blame to a culture of safety planning.
I come at it from a different way. We end up cycling patients through the system, often involuntarily, which is a severe deprivation of freedom without any long-term benefit. Medicine is an art, not just an algorithm. And a rigid adherence to protocol can erode the therapeutic rapport that is so essential for honest disclosure. If a patient knows that checking a box on a form leads to a safe room and a 72-hour hold, they stop talking. Urgent cares are not locked psychiatric wards, and demanding they function as such sets providers and patients up for failure.
I see where you're going, but let's drill down into that first point of contention. Universal screening versus clinical judgment. You called it a dragnet, but I call it a safety net. The ASQ takes 20 seconds to ask 4 questions about death wishes and intent. Research shows it has extremely high sensitivity, identifying 97% of youth at risk.
High sensitivity is great for catching things, but it's terrible for specificity. You're catching everyone.
But relying on clinical judgment fails to detect the quiet suicidal patient, the patient who is polite, who's there for a flu shot, but has a plan to end their life when they get home. The Joint Commission explicitly states that homegrown tools, basically doctors making up their own questions, are unacceptable. Only validated tools like the ASQ or the Columbia Suicide Severity Rating Scale ensure reliability.
I'm sorry, but I just don't buy that. Let me tell you why. You're conflating identifying a risk factor with truly understanding a patient. The source material regarding the ESS6, the ED Safe Secondary Screener, it makes a crucial distinction that a checklist often misses. It distinguishes between risk formulation based on subjective intent and objective lethality.
Can you explain the distinction you're drawing there? Because I think it's vital for people to understand the mechanics here.
Okay, so subjective intent is how much the patient wants to die. Objective lethality is how dangerous their plan actually is. A patient might have very high subjective intent. They're sobbing, they really want to die, but their plan is to overdose on a non-toxic substance, like a handful of multivitamins. That's high intent, low objective lethality.
Sure, but that person still needs help.
They do. Of course they do. But they don't necessarily need the same intervention as the next patient. Take the quiet patient you mentioned. They might be ambivalent, they rate their intent as low, but they're engaging in high-risk behavior with a firearm. That is low intent, high objective lethality. A checklist gives you a red flag for both, but the clinical management should be vastly different. That requires a clinician, not a protocol.
That's an interesting point, though I would frame it differently. The protocol doesn't replace the clinician. It prompts the clinician. A positive ASQ triggers a secondary assessment, like the ESS6 you mentioned. It ensures that the conversation happens. Without the protocol, that conversation might never start for the quiet patient. And once we identify that risk, we have to look at the operational elements. The Zero Suicide Toolkit outlines 7 elements, and transition is critical.
Transitions are where the system usually falls apart.
Exactly. The data is terrifying. The highest risk of death is within the first 30 days post-discharge, and particularly the first 7 days. The Joint Commission has even revised its definition of a sentinel event to include death by self-injurious behavior within 7 days of discharge. This tells us that a discharge cannot just be a piece of paper. It must be a warm handoff.
In an ideal world, yes.
It's not just ideal, it's necessary. We need a confirmed connection, an appointment made within 24 to 72 hours, and if we can't do that, we use caring contacts, postcards, texts, emails sent within 24 hours. It's a low-cost, high-impact intervention. It says to the patient, you are not alone. It doesn't rely on the doctor remembering to call, it relies on a system process.
That is a compelling argument, but have you considered the operational reality? You're describing a warm handoff in a fragmented healthcare system where outpatient providers are scarce. You want an urgent care physician to secure an appointment within 72 hours. In many places, the wait list for a psychiatrist is 3 months.
So we just give up?
No, but we have to be realistic. Urgent cares and ERs are facing boarding issues where patients wait for days for psych beds. Retrofitting a medical urgent care to handle this it's inefficient. The source material points to behavioral health urgent care centers, BHUCs, as a specialized alternative. They are designed for this. Demanding that a strip mall urgent care perform the same function as a BHUC is asking for failure. And regarding caring contexts, while nice, they don't solve the underlying lack of resources.
Resources are always a challenge, but I want to pivot to something you mentioned earlier about liability, because I think this is where the rubber meets the road. We have to talk about the legal duty to commit.
I suspected we would get here. This is where the philosophy meets the pavement.
I take a hardline stance here, based on the analysis of Maryland law by Miller. Physicians should have an affirmative duty to involuntarily commit foreseeably suicidal patients.
We cannot have physicians hiding behind immunity when they make negligent decisions that cost lives.
That is a dangerous path.
Look at the case of Chance v. Bon Secours Hospital. A patient, Brandon Mackey, was released after only 3 days on Risperdal. Expert testimony stated that drug takes weeks to work. He was released and he committed suicide the very next day. The court rightfully found that the premature release was a breach of the standard of care. If a doctor can release a patient who is clearly unstable without consequence, the system is broken.
But you have to look at the other side of that coin. Look at Williams v. Peninsula Regional Medical Center. In that case, a patient was released, broke into a home, and committed suicide by cop. The court gave the physician immunity for not admitting him.
And I argue that immunity is dangerous. It allows doctors to ignore the special relationship and the concept of foreseeability. If a suicide is foreseeable, the doctor has a duty to prevent it.
I'm just not convinced by that line of reasoning because it ignores the constitutional implications. If you remove immunity for not committing patients, if you punish doctors for letting people go, you are forcing them to practice defensive medicine. They will commit everyone just to avoid a lawsuit.
If everyone is suicidal, maybe they should be committed.
That is factually incorrect and legally repugnant. We have Supreme Court precedents like Addington v. Texas and O'Connor v. Donaldson. You cannot constitutionally confine a non-dangerous individual. The standard has to be dangerousness, not just a need for treatment. The state has a parents patriae power, yes, but it has limits. If we tighten the liability screws the way you want, forcing an affirmative duty to commit, we turn physicians into jailers. We infringe on the 14th Amendment liberty interest of the patient.
But chance shows us that dangerousness is often misjudged. Dr. Bell released Brandon Mackey when he was still responding to internal stimuli. That wasn't protecting liberty. That was negligence. The risk formulation we discussed earlier, it requires expertise. And when that expertise is applied negligently, there has to be accountability.
There is a difference between negligence and the inherent uncertainty of psychiatry. Predicting suicide is not like predicting a heart attack. It's fraught with variables. The Williams Court understood that protecting physician discretion, including the discretion not to admit, is essential. Otherwise, you clog the system with people who don't need to be there, taking beds from the people who actually do, like Brandon Mackey.
I think we agree that the system needs to catch the Brandon Mackeys of the world. But let's look at what happens when we don't commit. We send them home. And that brings us to safety planning.
Finally, an area where we might find some common ground.
Perhaps. I want to be very clear. Contracts for safety where a patient just promises not to hurt themselves are garbage. They have no empirical evidence, and they create a false sense of security. We need the Stanley Brown Safety Plan, a collaborative, written list of coping strategies.
I agree with the Stanley Brown model. It empowers the patient. It's not just a promise, it's a playbook for when the crisis hits again.
It is. It lists warning signs, internal coping strategies, social distractions. But the most critical part, the non-negotiable part, is lethal means counseling, or CALM. You must secure firearms and meds. The source material is explicit. Restricting access to lethal means is one of the most effective strategies for preventing suicide during an acute crisis. This is not optional.
I agree that CALM is effective in theory, but again, I come back to the operational reality of an urgent care. You are often dealing with intoxicated patients. The source material notes that patients who present with suicidal ideation while intoxicated pose a unique frustration. They express intent when drunk, then they deny it when they're sober.
Then you hold them until they are sober.
And turn the clinic into a holding cell? The logistics of that are a nightmare. And regarding lethal means counseling, try having a nuanced conversation about securing firearms with the patient who is agitated, intoxicated, or just wants to leave. It's incredibly difficult. I'm not saying we shouldn't try, but to mandate it as a non-negotiable standard of care that triggers liability if missed, that ignores the chaos of the environment.
The chaos of the environment cannot be an excuse for skipping life-saving steps. If a patient is intoxicated, they cannot consent to discharge. That is basic medicine. If they are suicidal and have a gun at home, letting them walk out that door without a plan to secure that weapon is negligence. The Zero Suicide Framework demands that we lead, train, identify, engage, treat, transition, and improve. It's a loop. If we break the loop because it's hard, People die.
The Williams decision protects the physician's right to use discretion. We need that protection. If every difficult judgment call carries the weight of a potential lawsuit, we will stop seeing patients as people and start seeing them as liabilities.
But isn't a preventable death the ultimate failure of the system?
And isn't the mass warehousing of the mentally ill a failure of our society? We have to be careful not to build a system that prioritizes the physician's legal safety over the patient's actual freedom and well-being.
We are at an impasse on the philosophy, but perhaps not on the data. We know that the post-discharge window, that first 7 days, is the danger zone.
Yes, on that, the evidence is irrefutable. Whether you believe in rigid protocols or clinical nuance, that week after leaving care is when we lose people.
So while I argue for the zero suicide framework, standardizing risk through universal screening, securing the environment with safe rooms, and enforcing a legal duty to protect, I do it because I believe it transforms the urgent care from a patch-up shop into a true safety net. We cannot accept preventable deaths.
And while I argue that we must preserve the physician's right to use discretion and protect them with immunity when they make those impossibly difficult calls, I do it because I fear a system that prioritizes liability avoidance over patient rights. We need better care, yes, but we cannot treat free citizens like prisoners in the name of safety.
It is a complex balance, and for those listening who want to understand the legal tightrope positions walk, we would invite you to read the source material on the Chance and Williams cases. It really highlights where the line between safety and liberty is currently drawn.
And deciding where that line should be drawn, that is something every clinician and every patient has to grapple with.
Thank you for joining us on The Debate.
Until next time.